Hello and welcome to the second episode of The Impact here in CTV. I am Amelia Nakitimbo. And like we mentioned during the launch last weekend, The Impact is a show for you to highlight the issues or the work that many of the non-government organizations are doing in our communities in partnership, of course, with also government organizations. Why? Because since the 1980s, there was a burst or a change on the scene in Uganda with more NGOs coming onto the scene, and they've been bridging the gap, especially where state actors are not able to reach. And The Impact is about taking you to the communities where that impact is being felt. And today we'll be discussing issues concerning universal health coverage, which concerns you and I. And in studio with me, I'm very comfortable to have doctors who are very qualified and have been doing so much work in our community to ensure that you and I have universal health coverage. And they'll be telling us what that means, how you can get involved, because it's not just a topic for technocrats. And later on, we'll also be discussing malaria, because we see more cases are coming up, so worrying that the Ministry of Health wants you to get involved, whether you're just a person who is receiving health care from your health community, or you are a medical worker out there, or you're a policy maker. This conversation concerns you. So this is The Impact. Sit and relax and wait for the knowledge that our panelists have with us today. I have in studio with me right now Dr. Freddie Ssengooba, who is from Makerere University School of Public Health. We also have Dr. Jimmy Opigo from the National Malaria Control Program at the Ministry of Health. Welcome, gentlemen.
Oh, thank you. Good morning, viewers.
Yes. So before we go any further, I'll just ask, in your move to take universal health coverage and to ensure that everyone is covered, do you find that people easily pick that, or do you have to use some words to break it down for people to understand? When you go, say, to my village, I'll not say which right now, and you're preaching that gospel of universal health coverage, how have you found the reception in community?
Understand? Great. Thank you, Martha, for the question. Yes, definitely. Universal health coverage is not something that communities may understand directly, but also to try and make it clear. This is more of a journey that we are trying to make with the objective of ensuring that all Ugandans, but clearly all countries, have agreed to this goal within the millennium, what we call now the Sustainable Development Goals, to see that we reach as many or even all people as possible with a higher package of service that covers all their needs over time, so that no one is left behind.
Right.
And as you can acknowledge, that is a journey that you cannot say you actually are selling more or less the journey, but it's important that all Ugandans are able to get all the services they need of good quality, but more importantly also at a cost that government and of course communities can afford, and where possible are free at least from suffering financial hardship in getting those services. Right. That is broadly the goal. And when you say universal coverage, we are looking, of course, within malaria, how do we ensure that we eliminate it, or whoever is really in need of care gets it, and without cost implications that might impoverish them. Right. Broadly, that is the goal.
Okay. Dr. Opigo, if I may come to you, how does universal health coverage and malaria, how do they come together?
This is a very important aspect in managing malaria. For a good malaria outcome, we would like anybody who gets fever to be treated within 24 hours. 24 hours. If you are treated within 24 hours, there is less risk of the malaria progressing to severe forms. Severe forms which will need you to be admitted, you may need a drip, you may need to get blood transfusion. Now, to have people treated within 24 hours, the services have to be near, they have to be available, affordable, and also socially well set. And we have made every effort to make this possible by some extension service within communities through, for example, integrated community case management of malaria. So in every village in Uganda, we have set through the public system and even private sector health entrepreneurs social health entrepreneurs, services available by a member of the community called a community health worker to be able to test people, treat them for malaria, differentiate between malaria and pneumonia, and identify those who need to be referred and facilitate the referral. And right now, the Ministry of Health and government has gone further to formalize community health system so that we have the tertiary, which is like Molago, very specialized, the facility-based, and now community health system, so that but also of quality, so that we can achieve this access to care and we address things early.
Right. And Uganda has been on a journey to ensure that we eliminate malaria, first of all, and also towards achieving universal health coverage. We're going to watch a very short clip, and some of the highlights will be made there, and we'll be discussing the issues that are raised in that clip.
Universal health coverage requires that every person should have access to quality health services on the basis of need and not the ability to pay. Such services should include prevention, diagnosis, and treatment of diseases so that people can realize their right to health, which is a fundamental human right. Good health is also necessary to increase people's productivity, thus leading to economic growth. According to the World Health Organization, worldwide, lack of affordable quality health care has continued to keep many people in poverty. And each year, large numbers of households are pushed into poverty because they must pay for health care out of their own pockets. Globally, every year, about 100 million people are pushed into poverty due to catastrophic out-of-pocket expenditure on health care. In addition, about 30% of households in Africa and Asia have to borrow money or sell their assets to pay for health care. The phenomenon of universal health coverage is ideally meant to tackle this problem and provide health care services for all. To achieve equity and financial protection, funding is expected to align with government planning, budgeting, and accounting processes. This remains a major area of concern. Experts advise that governments should endeavor to holistically promote health by emphasizing intersectoral collaborations using the health in all policies strategy. There is need for homegrown solutions to the problems that have hindered the achievement of universal health coverage in some countries. Such problems include the high population growth and the small tax base.
Well, doctors, what has struck me from that clip was that Uganda contributes one of the highest cases of malaria to sub-Saharan Africa, and I'm thinking we should be contributing other things, not malaria cases. How does that make you feel? And especially in the Ministry of Health, what are you doing to ensure that we have a positive contribution to sub-Saharan Africa, not malaria cases?
Yeah, first, indeed, it's the same, that we are the third most contributor of malaria in the world. And we are...
In the world?
In the world, yes. We are the fifth most contributor of malaria deaths. Not third, fortunately, because we have better care, so there is more survival out of malaria cases. We have put every effort to deal with this situation. First, there are a lot of environmental factors promoting this. You know, we are on the equator. We are water said. Mosquitoes need a temperature of about 26
degrees Celsius.
Yeah. And a perfect humidity, which we have, given that we are water said everywhere. So, and also we have the most prolific form of mosquitoes, the Anopheles gambi. We have the most aggressive form of malaria parasite, the falciparum malaria, unlike other places.
Which is different from the other countries sharing the equator with us.
Yeah, which is different. Yeah. The environmental factors here allow that particular type of very aggressive form of mosquitoes. Nevertheless, we are making a lot of progress and a lot of effort is being made. You know, in the last 10 years, we have moved from a prevalence of 42 to 9%. This is a record movement, but there's still a lot to be done, and we have now developed an accelerated reduction and elimination plan for Uganda.
For someone who has grown up in Uganda, I should say, malaria feels like a normal thing. I mean, people suffer from malaria every now and then, until maybe you now put us on the scale and you give those comparisons to say that we have some of the highest cases in the world. So when you say the cases or the measures that you've put in place to ensure that we move from the 42% to 9%, what are those factors or attributes that you believe have worked so well right now? Because we might take them for granted. I mean, as a Ugandan, I know that we have to sleep under mosquito net, but what are some of those interventions that you believe have worked so well in helping us to reduce malaria? Any of you can take it.
Okay, first of all, malaria should not be normal. You see, it destabilizes you for a number of days, taking medicines, getting away from work, spending money. So this is the narrative we need to change. If we change that, then the communities can contribute to its reduction. All diseases are fought most, not by the interventions, but individual action. The care people take for themselves. Otherwise, on the service delivery sector, we have managed to cover everybody with a mosquito net, but still it needs the people to sleep in. Beyond that, we have put the services available, but we need the people also to seek the care, allow their houses to be sprayed, and comply to the treatment. So for us to move faster, we need a very big effort from the public and the community. And one thing which has worked well in Uganda, just look at the panel here.
Yeah.
The people in academia are working very hard, trying to come up with ideas. They are doing research, advising us how best to go. The private sector, like he's representing Rotarians, there is Malaria Partners, international Rotarians with other bodies have come to get this multi-sectoral action. You heard in the clip, it talked about health in all policies and all people participating, because production of health is everyone's business. Yeah. And we are making a very good progress on that round.
Right. If I may come to you, as mentioned in the academia, from your research, what do you think we are doing right that has helped us to reduce these numbers from 42 to the 9 that we are on?
Well, thank you. Definitely a lot has been done. Even for us in academia, although we continue to see opportunities to improve, we note that malaria over the years, if you look from the 2000, 2010, where we are now, a lot has been done in terms of reducing the overall burden. But we're still number 3 in the world contributing to malaria. Given even our own plans, we should have ideally have reached elimination according to the government promises that have been given to the people. So over time, we've been trying to understand how can we go further in this road, trying to eliminate malaria. And of course, you can look at it from the fact that, okay, we've been able to reduce it from 10 years to where we are now. But when you look at the burden we still have, it's a lot. Right. We, as a country, we know we don't have a lot of money. You could look at it from the fact that malaria right now is consuming a very big part of the health resources in terms of the government budgets. If you, and I will use the example, my Ugandans have a very interesting picture. There are communities along the river, and there's talked of watershed being in the equator. All these factors are true. But also we have communities that have been able really to get to the goal of elimination in this country.
Like which one?
Northern Uganda around 2009 up to 2014, they set of about 7-8 districts that had spraying of IRS plus mosquito plus everything, mosquito nets plus everything else. Those districts, after about 3-4 years, they actually called. I remember there was a message from I think that time was the RDC of Rira saying, please come for the medicine. There is no malaria anymore in this community. And that was for the whole region there. So they were able to demonstrate that after doing this intervention regularly, over a period of 2-3 years, you can achieve elimination.
Right.
You don't need the drug. The people were happy, schools were open, children were not meeting schools, people were very happy in their fields. Initially very resistant against it, but then after some time it disappeared. Right. And then we got epidemics there.
Epidemics.
And that tells you that we can actually do well, but sustaining this is where the academia comes in. How can government be on this goal and really stay the course? You don't achieve coverage by giving 1, 2, 3 years and then withdraw, because that is not the way malaria works. You need to give it at a large scale, enough to reduce the mosquitoes.
Right.
But the point is, we have experiences locally. When you go to those communities, they tell you their story. They know the good times when this thing disappeared, when they had a lot of local efforts. And so we can do it. We just need to see how to reignite this effort. Both government, working with local leaders, working with government partners, working with civil society organizations. It is not something that is beyond our reach.
Right. And I think you've rightly said it, because like you mentioned, the panel is quite diverse. We have the academia, we have the civil society, and we also have academia and government itself. I'd like to bring in our guest who has just joined us. Thank you so much for making the time.
Thank you so much.
And I'd like to ask you, why malaria, of all things that you've had passionate about, you've been passionate about rather. Why do you think we should care about malaria, and on a Monday morning like this, we should be talking about malaria?
Thank you very much. We have all grown up suffering from malaria, and that sound alone of the mosquito cannot let you sleep. So that alone for us who come from the private sector, but also coming from organizations like Rotary, we felt it very important that the effects do not just go towards governments alone. They start from the communities, and we are the part of the communities. And therefore, we feel that malaria being one of our areas of focus, if I might say in Rotary, under disease prevention and treatment, we feel it is important to save as many lives. And when you look at the losses we incur every year because of malaria, over 80% are the children below the age of 5 and expectant mothers. And we believe with the new resurgence, even now other ages have been affected because of so many reasons, including climate change. Malaria is one disease which can be fought and defeated. And we can see that from areas where intervention has taken place, the numbers have really gone down. So I'm here in two positions. Number one, I chair the board for Malaria Partners Uganda, which is under Malaria Partners International. Right. Based in the USA in Seattle. I'm also the board chair in the Ministry of Health, working with Dr. Opigo here for Malaria-Free Uganda under that drive to have zero malaria by the year 2030. And on my part there and my team, the entire board, we are supposed to do resource mobilization and to make the corporates realize that it is indeed our mission, because malaria affects many of them at their workplaces, and a lot of resources are spent, including paying insurance, because malaria is knocking at your offices every day.
And I think that's an important campaign. Like I told Dr. Opigo, growing up in Uganda, we think it's normal to have malaria until we look at these cases to see how much we are contributing to the global world. So you're still telling us about, and I think it's a good campaign, and especially when you add the Rotarians, I'm very positive that we are going to achieve that by 2030. And I see the whole panel nodding, which means that you're all in agreement with me. So for a corporate or anyone in the community, because I think we had kind of left it to maybe government or whoever. How then do you want us to take part as an ordinary person, anyone sitting at home right now? How are we supposed to add that vigilance to make sure that we help you and help us all to reach that zero malaria by 2030?
It needs concerted efforts.
Yeah.
Number one, I'll start with you, the person hosting us this morning. Part of advocacy is very important, and the media houses tell the story.
Yeah.
And you have that far reach, even to the unreachable areas. And if I look at the people we look at, and these are the communities spread and scattered outside across Uganda, and more importantly now, northern Uganda, eastern Uganda, and part of central. Everyone today has at least a small radio in the garden. Now, using the media houses, and these the radio stations, a TV station, a print media, someone can easily know when we talk about advocacy, sleeping under the net, doing away with stagnant water, cutting down bushes. And there's so many interventions which are coming on board, coming from our colleagues from the universities who do a lot of research, from the National Malaria Control Division. And for us, we come in also to do resource mobilization. And resource mobilization does not mean cash alone. We can come to you and request airtime for free to run at the most critical times when we feel people are listening to those radios, watching TV, to send a message. And I believe with that mass action, we can have zero malaria by the year 2030.
Okay, very briefly, I'd like to bring in Dr. Opigo and also the professor. Why are we seeing a resurgence of malaria cases right now?
So we are experiencing a resurgence in 4 regions of the country: in Ankole, in Toro, in Kigezi, and in Bukedi. In Kigezi, we know the reason. It is migrations. Many people in Kigezi go to farm in Bunyoro, and they come back for Christmas, bringing back malaria home, because Kigezi normally has very little malaria.
Because it's very cold.
Because it's very cold. Yeah. So those who come back bring back malaria and infect people who are non-immune in that area. For Ankole and Toro, we have not got the exact explanation why this is happening.
And I think Professor's department will help us here with the research.
In Bukedi, where we are experiencing a very severe form of malaria epidemic right now, with so many children needing transfusion, passing blood in urine, and we are losing. The number of cases rose by 4 times. The number of deaths rose by 3 times. It's been very, very serious. And actually, people even reported it in Parliament as a strange disease. We think there are a number of things at play. This is an area we normally spray. We change the chemical, but this chemical works in other places. We don't know whether it is the local water, the local mud on the wall, but this chemical doesn't have a smell like the previous one.
Yeah.
So people doubt if it is there. And we know some people have, they paint or smear their walls. People in Kampala may not know what I mean.
I know they come from the village as much as they're in Kampala, most of them.
So this seems to have been covered. But also the presence of IRS made communities complacent. Your house is sprayed, so they abandoned use of nets.
Yeah.
The health system also there was not expecting a lot of malaria, so they had less medicines. And because we are spraying, we did not put this community level service I talked about, ICCM, in that place. And also the health system there has mostly health center tools, no health center 3 at sub-county level, which could manage severe form of malaria.
Right.
So this is what we think is happening in that place. But we have responded very, very firmly. We are almost completing spraying the homes, I mean. Everybody who comes to the facility, whether with a malaria complaint or not, whether an attendant or a real person, we test them. Everybody found in malaria, we discharge with a mosquito net. We have put there advanced medicines, and once we detect that a particular village is sending more malaria cases, we visit that village and test everybody and treat them and give them a mosquito net. So we should be able to close it down early next month.
Okay. Well, there you have it. The Impact is going to take a very short break. When we return, we'll be having more discussion on the indoor residential spraying, like he has mentioned. This is a show about how we can bring impact in your community. It concerns you, it concerns all of us, and we want to see positive change in this country. So the Impact takes a very short break. We'll be right back.
CTV is now on StarTimes. You can now catch all your favorite programs, our daily comprehensive news bulletins, and so much more on StarTimes channel number 248. Stay tuned for a world of endless possibilities. CTV. Don't blink. As we embark on a journey to realize our full potential, we all need expanded minds and limitless possibilities. We need to be accurately informed. CTV is your growth partner. With reliable, in-depth news, we tell the story from all perspectives. We bring you the story in real time. Catch our comprehensive daily bulletins in Juba Egorodie at 7 p.m. and PM edition at 9 p.m. CTV. Don't blink. Now showing on CTV. Start your day fresh with TV unlike anything you've seen before. Wake up with Sunrise at Sea for your daily dose of freshly cut stories, trending online discussions, self-care and constructive conversations. No topic is off limits. Watch Sunrise at Sea every weekday at 7 a.m. Now showing on CTV. Don't blink.
Welcome back. You're still watching The Impact here on CTV, a show that's about bringing the impact that's happening in your community, and that is work that is mainly done by non-government organizations, but also working in collaboration with state agencies and the civil society. And before we went on a break, we were talking about achieving zero malaria by 2030, and there's a launch for that is going to be coming up. But we're also talking about the areas which are seeing a resurgence in malaria cases right now. And Dr. Jimmy Opigo mentioned 4 key areas, and then he talked about the interventions that are being done, which includes indoor residential spraying. And now we're going to look at what government has been doing over the years. There was some work that was done around 2018 and 2019, and we'll take a look at that. And after that, we'll discuss what has changed since then.
When she first told her story, it was to her fellow village mates. But that was a story that wasn't unique to Jennifer. Everyone in Bungatira village shared it. The malaria burden affected everybody, so they spent money seeking care. Some children died. There were immeasurable indirect costs as well. Time was lost in the garden, at home, and for the children at school.
Currently, the government is looking for savings, is looking to boost productivity, is looking to see that people at work and people in school. All those things, by the way, malaria reduces them. If your child is sick, clearly won't go to school, the teachers won't teach that person well, will not have enough blood, we call it anemia in medicine, he won't be productive.
Today, Jennifer tells a different story. It is a story of change. Her story changed with a campaign for indoor residual spraying in her village.
Dan weng ti mabe malaria peke no tena ma burete net weng ti mabe no bon tu mai ken wa a wa tiere poro ma kom wa ti mayot wa lego ma eni dang ma chake eni ngu kel gu mede ki kerne ki dong net be ki poke med mu kene dong mu kene ma pol peke ano poyo.
Uganda is the second largest contributor of total malaria cases in East and Southern Africa.
When we started this work, one of the big burdens that we see would delay us to get to the goal of UNHCO, universal coverage, is going to be malaria.
Domestically, the burden of malaria is enormous and persistent. Jennifer's story gives us an insight into what indoor residual spraying can do. IRS for malaria is the surest way to prevent malaria.
Indoor residual spray is that inside the house you can use the same chemical on mosquito nets but apply it on the walls inside the house so that mosquitoes can reduce within the household. And if you do that, chances are that you have like a net on the wall.
Indeed, government has proposed large-scale indoor residual spraying as one of the major components of the interventions for the current malaria control efforts.
It has been done in northern Uganda since 2007, I think. In about 6 or 7 districts in northern Uganda, yes, we are having this program twice every year, spread in the community, covering nearly 70–80% of the houses. And after about 3 years, they actually declared that the medicines they had for treating malaria were not being used because people stopped having malaria in those districts.
The rate of malaria was completely reduced. People were just saving money, which they used to, the money which they used to spend for buying malaria tablets or malaria drugs, and they were just saving for other activities like for paying school fees.
Kick Malaria Out of Uganda is an ongoing campaign.
The mass action against malaria, that is to say, everybody should be involved. Residual indoor spraying. If you spray the walls, you spray the walls with something which lasts many months, but it needs more effort.
But this business of worshipping the mosquito is what is killing us. And let's be honest to all those who think killing the mosquito is a problem. Those who think spraying the mosquito is a problem. Let's talk to them honestly. When our children die, they are not there to bury them when they're still praising their mosquitoes. Let's have an honest and frank discussion about the cause of malaria and how we must deal a final blow to the problem of malaria by attacking where it comes from.
Uganda's economy is highly resource-strained. There are innumerable competing development priorities and needs. Options for cost minimization for IRS implementation are therefore inevitable if universal coverage is to be achieved.
So we decided, let's look at what does it cost, or what is stopping us from scaling it up. The era of universal coverage is that you scale up all these interventions to an effective level. So they told us the reason they are not scaling up as government is expensive. So we wanted to understand why is it expensive. We went to Gulu, we had the big engagement, we talked about these engagements. We organized all the districts that had spread, figure out. And then we figured out that, okay, the areas that we can cut off that were not necessary to. So we went through a costing, rigorous costing, but also costing from a poor man's perspective.
There is a perception that goes around that IRS is actually a very, very, very expensive intervention. That perception is driven by project-led IRS data.
Before this study was done this year, in 2000...
A study codenamed Financing Indoor Residue Spraying for Malaria Prevention in Uganda, Options for Cost Minimization provides evidence on cost reduction strategies for scaling up IRS across the country.
Our data come from a district-led approach of implementing IRS.
The study was conducted by Makerere University School of Public Health through a 5-year European Union-funded SPEED project. SPEED stands for Supporting Policy Engagement for Evidence-Based Decisions for Universal Health Coverage in Uganda. The study was spearheaded by Uganda Health Consumers Protection Organization in conjunction with the Economic Policy Research Center. Accordingly, the findings suggest that more emphasis or investments in malaria prevention using IRS is a less costly venture for government to take up and presents cost-saving opportunities in the fight against malaria, hence a seemingly more sustainable measure. The study analyzes costs of countrywide rollout of IRS using a district-led approach of implementation, examining the cost implications of implementing IRS in a phased manner.
We now have a figure which shows that with about $8 per household, you can spray successfully. And that means that almost every person in the house, you have around $3 or less.
So the key finding tells us that implementing IRS using an integrated district-led model is the way to go. It provides government with cost-saving strategies to achieve an effective protection against malaria.
I feel that it's high time we eradicated malaria from Uganda. And since the district form of providing this service is cheaper, I strongly support it. 2020 is around the corner, so we should stop dilly-dallying and go straight to what will arrive us to eradicating malaria by 2020. We are a decentralized form of government, and so this also is going to strengthen the districts in many ways, including human resource.
But for us, our interest is the sustainability. Sustainability, which is of interest to us. For me, my experience with the district-led things, where it is integrated into the health system, it is more sustainable. It may have some weaknesses here and there, but it is much cheaper for us. What we need is the medicine, the spray, then few gadgets. We teach our local village health teams, the healthy ones. They are willing to work.
The drugs will be within the sub-county since we have the store. More so, yet also since it is going to involve our community members. That is another way of giving employment opportunity to our community members. And then the sub-county will have a better record. It will give us a better record for keeping even to know how many people were being employed and more people who are their house has been sprayed.
Government should utilize existing district local government and community-based structures, as well as spray logistics on IRS pilot districts as a basis for minimizing the cost of IRS implementation.
A project will use expatriates, for example, but using the integrated district model, the districts can utilize locally available resources.
Although the estimated annual cost of implementing long-lasting insecticide nets is comparable to IRS cost, IRS may be the most optimal option based on effectiveness criterion.
You're going to be in the house, you're going to be not under the net for many hours. And even those that have nets, studies have shown that less than 50% of the people who have nets sleep under them. So there are many behaviors in the community that make this net not to be effective. Others feel suffocated sleeping in a net. If you apply it on the wall, there are many things you will reduce. People won't have those challenges.
IRS is also cheaper than malaria case management. The annual cost of case management more than doubles that of IRS. What is being done is to disseminate the findings of the study to various stakeholders for support and influence policy for countrywide scaling.
Because with the mosquito nets, it doesn't end at procuring it, it goes also into utilization. You can procure it and it's not well used and still you end up treating those people. So if there is this that you don't need somebody to monitor whether it is used or not. I want to say I wouldn't see anybody resisting a solution of this nature in Parliament.
I personally agree with these cost reduction strategies that have been highlighted here, and I think we need to focus a lot on them and also sell them to the different stakeholders that we have.
Spray operations, including determining the spray rate. That is how many structures can be sprayed.
Now when you go to northern Uganda where this thing has been over time, for them there is no more advocacy required. People even call and say, now it is 9 months, my house has not been sprayed.
I promise to be a good agent. I will support your program if you can reduce the malaria, if you can reduce the mosquitoes, because that's one thing people tell me when I go out there. My home will continue to be a demo center.
Have a number of engagements with policymakers, not only at national level, but since we got it from district level, we want to engage also the district and the community who are affected by malaria. We want all of them engaged and they give options that can cause a reduction in the implementation or in having this intervention.
IRS presents cost-saving opportunities for government in the fight against malaria. Consistent domestic resource mobilization and funding, supported by a strong political will, is paramount.
Well, there you have it. A number of issues were raised in that documentary that we just saw. I think I had a promise about 2020, and now we're in 2022. But just for those who might have just joined us, you're watching The Impact, and we have a very interesting panel that is here to ensure that we do not have malaria by 2030. I admitted to Dr. Opigo that for me growing up in Uganda, it's very normal for anyone to get malaria, and he says, no, that's unacceptable. You should not accept to call malaria quite normal. And if you've just joined us as well, we also have someone who has joined us on set. And her mission is to ensure that we live in a Uganda where healthcare systems guarantee full enjoyment of rights to health by all, so that when you go to access healthcare services, you're not just, being treated and you go away, but you enjoy the whole process of being treated even before you get treated. So Robinah, Kaitiritimba, welcome to the set.
Thank you.
Yeah, and I'll reintroduce also Ken Mugisha, the man we shall hold accountable. We're in his driving seat. He's taking us to 2030 to ensure that by 2030 we do not have malaria in Uganda, and he's bridging the gap between the private sector and the public sector, and we do appreciate the role that you hold.
Thank you.
Yes, so I'll take you back. We also have, of course, Dr. Jimmy Opigo, who is on the National Malaria Control Program, working with the Ministry of Health. So this is just a very strong team showing us what is going on behind the scenes to ensure that we do not have malaria in Uganda. And the reason why we're having this conversation right now is because we've seen a surge in the numbers, but also even before this surge that happened just a few months back, over the years, Uganda has been contributing a very high number of cases, not just to sub-Saharan Africa, but to the world, like Dr. Opigo mentioned, for those of us who've been with us since the top of the hour. So we have looked at residential spraying, internal residential spraying, and you mentioned that it's one of the ways that you've been able to reduce the cases of malaria, especially in northern Uganda. And earlier on, you also highlighted that you've faced a challenge in Bukedia right now because you're seeing that the same is not working. How about the other regions in Toro and in Ankole, like you mentioned? Has that been tried, and what's the response right now?
Thank you. We would like to make actually residual indoor spraying almost universally available. The challenge has been the cost, and from the documentary, these were efforts to explore other mechanisms of deploying it and how to make it cheaper. Now, in Ankole and the Kato corridor, we intend not to deploy IRS, because we are collaborating with agriculture. Mosquitoes are actually terrestrial. They are outside. Yeah. They also feed on animals. Now, the same chemical which kills ticks also kills mosquitoes. If you see the low level of malaria in Ankole, it's not our work. It's actually the work of agriculture. Yeah. But which is the work of individuals there. Because animal health is done by the people. It's not delivered by government. Government only does the policies and ensures that the chemicals are effective. The other thing happening well in Ankole is they are dealing with housing. Housing is a major malaria control tool. A house which is well screened is as good as mosquito nets. Because mosquitoes bite mostly in the night, they need to get into your house. So a house which is well screened contributes a lot to malaria reduction. But if on top of that there are behavioral practices like closing windows, okay, then you achieve even closing windows just by 5 o'clock.
Yeah.
And then sleeping under the net, you achieve even more. However, in Ankole, we have worked on a private sector arm of making sure that we have chemicals on the wall. For example, the paint is being heavily used in Ankole, funded by the people themselves.
Where is the paint coming from?
Now, paint, the way we put, for example, vitamins in Blue Band.
Yeah.
Okay, the way we do food fortification. So also malaria chemicals, you can use another vehicle for delivering it. It's called home decoration for malaria control.
Right.
There are several examples. There is Ines Fly in the country, but Plascon, which is made here, has also incorporated this. It was launched actually also by government some 3-4 years ago, and some communities have adopted it. So instead of first painting your house, then you come and spray on the wall. Mm-hmm. You use a paint in which already the chemical has been incorporated. And they designed this chemical for slow release. Okay? And it can last there for over 2 years. And they have designed a booster after that. You just do a small booster, and then you are further protected.
That's after like 6 months?
No, after 2 years.
Yeah, right. 2 years.
Yeah. Right. After 2 years.
That's quite effective.
So these technologies exist. And quickly in line with what appeared on the TV, where the president was calling on all people from the concept of mass action against malaria, all sectors, all people to contribute. So private sector, for example, has developed technologies, have made it available. The logistic system, they have made it available. Even aerosols, which we spray like doom, things we put in the socket to repel, screening of windows. This is private sector, commercial. But private sector, even corporate, as we said before, have come together. They are raising money. They are making advocacy. Okay,
right. I would like to bring in Robinah right now very briefly. The work that you've been doing historically is you see where maybe government has not seen, and you advocate. You've been advocating and have caused a lot of change through the organization that you're leading. What new interventions do you think we need to help fight malaria and make it extinct in Uganda?
Thank you. I think that government, we have made progress. If you see that we have moved from 320 people per day a few years ago up to 15 now.
Those are deaths?
Those are deaths.
People dying of malaria every day.
Yes, but also there are those that we don't count and don't see. So, but malaria, the mosquitoes are still here. So government has to have a comprehensive strategy, and I think the most important thing is getting the communities on board. If you see how we are, Dr. Opigo is talking about closing doors, making sure we don't have water around our homes, but most importantly, being able to go for treatment early and knowing what mosquitoes do to you. So that's a lot of empowerment that needs to be done at the community level. All these strategies cannot work unless the community is on board and is aware of what the dangers are and is participating. But there are other, what we call health determinants that impact this malaria problem. One of them is nutrition. Because if immunity is very low, and that's what is happening to our mothers, that's what's happening to the babies, if immunity for anybody is very low, it is very difficult to survive malaria. So there are other factors on nutrition, on education, on water and sanitation. I think that government has got to move from clinical care to see that we are investing heavily in prevention. And I think that's what the president was talking about. IRS is one of them, but a narrow focus on one area, I think, may not address the bigger picture and sustainability.
Right, and that actually brings out a point that you had made previously, where you said we need to move away from looking at, health interventions as health solely, because it also has a contribution economically. And when you're mentioning things like good feeding, there might be factors that are limiting the communities from having very good feeding and information. But just to take you back on what you said, that the community or the population needs to be involved. For us to have the statistic that we're having right now contributing, third in the world, it means that something is fundamentally wrong. So how can that communication be put to the public so that they understand the gravity of this matter, that we don't have to have people dying? Yes, we've improved, but what more can be said to the community level so that we are all involved right from the grassroots?
One of our disappointments, I think, has been the performance of local governments. We pay very heavy administration cost. We have local councillors, they are all over the place, and if they can mobilize for elections, for instance, and everybody turns up and we even fight over elections, why has it not been possible for government to hold local governments and administration accountable for creating a movement for health beyond just malaria, so that we have the local government people who are paid on the ground, mobilizing communities, inspecting houses, making sure that people close their homes early, looking at water and sanitation and agriculture and feeding. And there are other factors that include gender that are also in there, you know, gender-based violence, girls not going to school, even boys need to go to school.
Right.
So it is important for us to help a movement for health that looks at the entire perspective of the health determinants, so that we have one group of people doing everything at community level, mobilizing community, creating a movement, motivating people to understand what health means and the contribution that it makes in their lives, because that is how we can have sustainability.
Right. You had earlier in a different conversation that had been held, an engagement, you mentioned that the work that you're doing with advocacy, at some point you're constrained by the funding. And all this work that you're talking about, mobilizing communities, I mean, we know that, for example, electoral campaigns are very expensive. So if you're to mobilize the community in the same way, you'll need a bit of funding for that. And I'll bring that to Ken as well. How are we doing financially right now to ensure that we reach that zero malaria by 2030?
Yes, part of activities under resource mobilization, we've written to over 200 corporates today.
In Uganda?
In Uganda. And the response is very, very high. On the 30th of this month, we are launching under what we call partnerships with EcoBank. And we're launching what we call Zimbli to have an initiative about zero malaria on entire African, but EcoBank Uganda has come on board with Malaria Free Uganda with a pass of initial $120,000 for a year.
That will cover the entire
for a year.
Uganda, yes.
And this is just a beginning. We are looking at upping the game. And the more EcoBank is grounded in Uganda, the more resources they can commit towards this cause. And that is just one of them. We've just talked about Plascon. We had a meeting with their team, and to commit them that in case there's an outbreak in an area, can they provide that paint, and as part of their corporate social responsibility, because for them they will not give you the cash, but they can provide that paint and paint homes as a way of fighting malaria in those communities. So, like I said earlier, for us, the donations we get, it is not cash alone. Anything which can reduce malaria and outbreaks of malaria, we allow everyone to be on board. And Robinah, maybe because we are to do resource mobilization as Malaria Free Uganda, she can work with us. They can bring on board what their challenges are, if they're financial. Even if they are not financial, we can come to them that under the partners we've received, they can be of help to the organization, because our mission and vision is the same.
Right.
Yes.
What words are you using to persuade these corporates? Because we might have, I mean, corporates have very many priorities that they want to have. What words are you using to ensure that they join this campaign?
I call myself the official beggar for any initiative which saves lives. I commit a lot of my time and resources in making people realize that any challenge in our communities, we should be the first people to respond.
As corporates.
When we talk about malaria, there is no corporate who will tell you that they don't have absenteeism at their workplace because of malaria. Number one, either the staff themselves or their families.
Right.
You cannot come to work and feel comfortable when your child is dying of malaria at home. You'll find a situation to tell your bosses that you're going to be away from work, and everyone will understand. Now, that one also affects productivity at the workplace.
Right.
So the corporates spend a lot of money in insurance. Now, if you have a solution to bring that problem to zero, why don't you join in? Why do you keep on prolonging it, wasting more resources, spending more resources, yet you have a solution which is going to take less than 10 years and a solution which is going to go away forever?
Right.
So it makes me very, very happy to see that when I explain to people, they understand, but the challenge, they have it at their doorstep.
Right.
Yeah.
Just to bring you back, I know you hinted on what the community can do or is doing, but what more do we need to know? I know, for example, you highlighted some of the issues in the health rights bill that you're bringing forth, and even the publicity of that bill is not there, and these issues that we are talking about could also be helped or accelerated once that bill has been put in place into an act. So what does the population need to know to help in this fight?
One of the other difficult challenges that is not being mentioned is the quality of service. So what we do at community level as individuals, so we go, when we have an ailment, we are not feeling well, we walk to the next drug store and buy a pill and take it and share it, and then we lie down, and meanwhile the resistance is going down. And this is an area that the community needs to take responsibility for.
I think they do that because usually consultation fees are quite expensive.
Are very expensive.
Or even working somewhere, you know, it's not easy. Yeah.
Yes, and they don't know who provides quality care. But also there are no alternatives. One time we closed many drug stores that were illegal, and the community said, you can't close these drug stores. This is where we go at night. So government needs to take responsibility for monitoring and making sure that the people who are providing services at community level are legal and they are providing the right quality of services. Even the other one is when we go to a clinic and the diagnosis is poor, and you have a malaria test that is negative, sometimes they tell you you have residual malaria. What does that mean? And then we get onto drugs, and you know that government has had to change many times from one drug to another because the resistance has gone down. And government needs to address this problem so that the community is confident that the services are of quality and they will address the problem.
Do you find that the population is not well informed on why we moved away from Fansida, quinine, chloroquine, now to Coartem?
There's a lot of confusion down there on that. And as we were talking about the spray, the paint, and even IRS, the community is not very on board.
Yeah.
They don't know. I have heard people say, if this drug or paint can kill mosquitoes on the wall, what about my children in the house?
If they touch the wall.
What about me who is sleeping in this wall? And then they are saying close the house. So all these things. And I think for me, for us as community, we know that the village health teams are good. However, this is an extension. We agreed in policy that this is Health Center 1.
Right.
So it provides service. It is an extension of the service provision. It is not a community. We need to have others like health unit management committees who are not in service provision but are representing the community. So we have an extension of the service, but we do not have a community voice. I think that, and when you ask village health teams, they say, well, I provide services for family planning, I provide services for malaria, but they are not, and that is where the bill is very important, that people know their rights, they are also able to protect their rights, because the VHT is protecting the rights of the service provider. We need to have people at the community level who are part of the community, are representing the community voice, are asking those controversial questions.
Right.
Maybe can I make a comment about what Robinah has been talking about community teams? We've had interventions in that area, We did in Katakwi. You'll remember when Pilgrim was working there under Malaria Partners Uganda. We provided megaphones to community leaders, moving around, mobilizing people about the spraying, but also telling them about interventions on how they can protect themselves against malaria. So it was a beginning which can be rolled out everywhere. Yeah.
How did you recruit those VHTs?
They are not, those are different from VHTs. These are community leaders who were trained about malaria, to talk about malaria. But people can believe in.
Yes.
Because whichever program you do, it must be community owned.
Yes.
Otherwise, if it isn't community owned, you're wasting your time.
Right. I would like to now go to Dr. Opigo. She mentioned something very critical about the reception of the communities. You've had a lot of success in northern Uganda. How did you get the community to buy into that indoor residential spraying, which even helped to reduce the cases of malaria in the region?
Now, for any intervention to work, beneficiary involvement, designed to make it socially acceptable, participation is part of our design. We do extensive consultation and we explain to people, and where possible we use community members to deliver the service. For example, we select those spray operators you saw are selected by the community. We encourage also women participation, and then we use also mobilizers who are community members plus the LCs, so that they encourage people to open their houses and explain the entire thing to the community.
And the challenge on the fear of the chemicals that she talks about.
Yes, let me come on that quickly because that's very important. Now, chemicals are designed to harm organisms or germs. It can harm human beings.
Right.
Depending on how it is used and how much is used. But wait a minute, we take chemicals which are medicines in our bodies to kill worms, for example, which are bigger than a mosquito. How come it is only killing the worm? We take inside to kill the malaria parasites. How come it is? So in the process of designing medicines, you design and test several times, first in a lab, then in a guinea pig, then in healthy volunteers, to make sure that they are safe for human beings. But they will still have side effects.
Right.
They will still have side effects.
Because like we've seen with some of the mosquito nets, you'll have itching.
Yes.
Yeah.
And also they have to be taken in the correct dose.
Right.
Enough to kill those diseases, but not enough
the person.
Yeah. Any medicine taken in high doses can kill the human beings or can harm them. Right. This is fact which is known. And we have good regulatory arrangements through NDA to make sure this is safe. Now, for chemicals for killing mosquitoes, one, we use, in the mosquito net, we use pyrethroids. Pyrethroids are plant-based. They are safe for people. The one on the wall can harm people. Okay? So we make sure, but not when applied on the wall. Okay? When still in its socket, if you drink it like rat poison, it is a problem. But on the wall, we apply, and after mixing, it is not dangerous to people. Actually, it is applied by people. Okay, although we protect them with full PPEs, you can see. So in most of these things, we balance safety and benefit. There is always some level of risk, but we balance safety and benefit.
Right.
Yeah, the benefit is always more, but you need to deliver it in a safe way. You need to dispose the balances in a very safe way, but also not to harm the environment. And we have also methods to deal with in case those applying are poisoned. Not users, those applying, because they are having big volumes. Okay? But here we just spray on the wall and it dries there. My house is sprayed. The president's house is sprayed. State house is sprayed. Minister's house is sprayed. I think your house is sprayed. Yeah. No one can pass a paint. The paint is done by people, is applied by people to be used in houses. UNBS is here to protect people. We have gone through all these processes.
Right. So as...
and the confirmation from Dr. Opigo is that we need to do a lot of work.
Mm-hmm.
If he is explaining that to me and you, and we are listening and thinking, is this so? Is his house sprayed? So you need a lot of time, you need a lot of investment. You also need the message carriers. The messenger must be somebody who is technically competent to explain, but also acceptable by the community so that they can believe what they are saying.
Just quickly, like in Plascon or the others, the chemical being used is the same one being used in Doom or Kill or Heat, which we spray in our houses and even breathe in. Okay? But in this case, it's formulated to be applied on the wall. Yeah, but it is true, we need a lot of explanation. Anything chemical, people have their reservations about it.
You mentioned tick, the same chemical that is used for ticks, having helped in Ankole. Can that also be adapted to help in the region and also in Toro?
Yes, now where there is cattle corridor, for example, Karamoja, if there was good tick control, would benefit a lot from its other effect on malaria. In this other side, there is no big cattle population to have an impact. So the chemicals are the same but formulated differently. By the way, even antibiotics for injecting animals is the same one which human beings take, but you formulate it differently and in a dose for animals.
Right.
Yeah, but in terms of chemical structure, they're the same.
Okay, so we are almost coming to the end of the show, but I would like each of you to also send a very specific message to whoever is watching. And we have a very diverse panel, but she has highlighted that we needed to create another seat for someone from the community. So you all make a specific message to whoever is listening and whoever they are, maybe the community person or public and private or government as well. You could even be sending the message to government on what we need to do. Though as we do that, I'll start by asking, where were we and where are we right now? If you can reiterate that, and where do we want to go as we try to fight malaria and within which time, so that I know as I'm listening to you what role I need to play, and everyone else listening to us knows what role they need to play to ensure that we have no malaria in Uganda by 2030.
Okay, now where we were was a situation where malaria was the biggest killer. People were sick. Where we are now is malaria is getting under control. Kampala, I know most viewers and listeners have not had malaria the last 1 or 2 or 3 years in their house. Where we are now is everyone is getting engaged. The president, you can see, is calling on everyone to act. The business people are coming to help us. Civil society is coming to help us. Industry is helping us. Business people, to the extent that they have formed malaria-free Uganda, the likes of Bitature, the likes of CEO of Centenary Bank, Eco Bank you have had, Biodiversity Fund, the tourist board, okay? Because, for example, tourists fear malaria. Is one of the reasons they don't come here, because they come from a place where there's no malaria. And when they're here, they are swallowing a medicine every day not to contract malaria. You can imagine if we deal with this.
Which is such an inconvenience for tourists.
Yes, yeah. We are at a point now, individuals are starting to take action, and that is where my call is. We would like this not to be the business of government. It should be the business of individuals. The way we made effort to keep ourselves COVID-free, notwithstanding the other effort of enforcement by police and the campaign, but most of the benefit was from all individuals wearing a mask, sanitized. They bought the masks, they bought the sanitizers, they kept themselves at home. We can do the same thing to fight malaria, and that is where my real appeal is. And this coming World Malaria Day, which is going to be next month, would like to theme it around domesticating the malaria fight.
Right.
Okay. We want to domesticate the malaria fight.
Okay, 30 seconds for Ken and Robinah. Your last message to us.
My next message is to mobilize all the corporates in Uganda and business leaders, because the trends of the day now is that many of our donors are getting tired of us, and they're promoting initiatives for local fundraising drives.
Those are global donors that you mean?
Yes, in addressing our own needs. And we shouldn't wait for donors to close the tap. We must start from ourselves. Many resources are spent on seminars and what. Can we divert some of that to save lives? And that is my call. So whenever we come knocking at your door, be ready for us, because Uganda is for all of us to enjoy, to make sure that no life is lost. And most importantly, because of malaria, a disease which can be fought and fought forever.
Right. In just 10 seconds, your message to the viewer.
For me, I think there is nothing more important than prevention, and it is good to see government focusing on this, but also empowering communities. Sustainability is about people taking responsibility for their own health and understanding why health is very important. So in that vein, as we look for health insurance, we don't want our money to be finished by malaria before we can get to other things. So the Patients' Rights and Responsibilities Bill is important for empowering patients and making sure they take responsibility, but also holding service providers accountable.
Right, thank you very much. Well, there you've had it. This is a conversation about ensuring that malaria is no longer normal in Uganda, like many of us know it to be. That's been The Impact, and I'm your host, Amelia Nakitimbo. More conversations are lined up for you, and also the Month of the Woman returns tomorrow, same time. Goodbye.